Thank you, Dr. Vaishali. Uh, well, my job is to ask questions and not to approach to a young person with fracture. So we had recently a case, a 40-year-old female, Kalavati. She presented to St. John's Hospital with complaints of bone pains, fractures with trivial trauma, bony deformities. It's basically a malunion since the last 11 years, so around 29 years. Apparently asymptomatic 11 years ago when she noticed right-sided leg pain, mainly on the shin of tibia, noticed difficulty in walking with aggravation of pain while walking, symptomatically managed with analgesics, pain persisted. She had a history of trivial trauma and sustained fracture to the shoulder. It was actually a clavicular fracture, and advised shoulder brace. Can you put this up, the timer? Yeah. So she started walking, she started taking support of nearby objects to walk around. Since last 4 months, she walks with a walker but needs two hand support for getting up, getting down from the bed. History of lower back pain since the last 1 month, non-radiating, increasing with movement. She has history of alternative medicine use in the past, stopped since 5 years. No history of renal calculi, polyuria, polydipsia, early loss of multiple teeth, no history of dental pain, dental surgery or dental caries, diagnosed with right leg fracture, malunited during the same visit, gradually bone pain worsened, patient was able to do a regular exercise initially without any assistant, but then she noticed getting up, difficulty in getting up to the sitting position last 2.5 years, along with difficulty in climbing stairs and difficulty in combing hair due to restricted movement of the shoulder due to pain. Past history, childhood normal, no hearing loss, normal menstrual function, but last 7 years she's on OCPs. History of short stature in sister and mother, blindness and deafness in the daughter in one of them, history of deafness in sister, son, 2 children, history of IUD in first pregnancy, obstructed labor in the last pregnancy, stillbirth, this was 15 years back. So a bit complicated case, it's come to us, how do you manage this? So you must remember that the ISCD recommends Z scores rather than T score to be categorized bone mineral density among premenopausal women. And in contrast, IOF recommends, that the International Osteoporosis Fund recommends the use of Z scores for women less than 30 years in whom the peak BMD may not have reached, and T scores for premenopausal over 30 years old. And the ISCD also says that a Z score less than 2 be defined as low bone density, don't tell it as osteopenia, low bone density, or BMD below expected for age. So this is the definition. And when you have a Z score more than 2, then we are saying that BMD within the expected range for age. So this is how the definition is. In a young, don't say osteoporosis. You can say when, I'll tell you. They concur on 2 points. Osteoporosis should not be used to describe premenopausal women with isolated low bone BMD, and osteopenia completely avoided. When you say osteoporosis then, so those with a low BMD, that is Z score less than 2, with additional risk factors, hypogonad, chronic glucocorticoids or hyperpara, or those with a fragility fracture. What do you mean by fragility fracture? Fall from a standing height, you're sitting, you fall, or you are running at a speed which is less than a run and you fracture. That is known as a fragility fracture, excluding fractures of the digits, face or skull. Whereas the IOF says osteoporosis in premenopausal if the T score, okay, so IOF less than 2.5 and known secondary causes for bone loss or fragility fractures. So you must know about peak bone mass. So this is very important. If you have a very good peak bone mass, you end up having less fractures. So this is a major determinant of premenopausal BMD. You achieve by around 25 to 30 years as measured by DEXA. 75% contribution by genetic predisposition, mainly low peak bone mass. Illnesses, medications can also lead to a decrease in peak bone mass. Normally, after puberty, you achieve it by around 20s, early 20s. Some gain can happen up to 30 years. So as I told you, largely genetically determined, adequate calcium intake and physical activity. So that's why we say there are times in birth after birth, where you have the maximal peak bone mineral accretion, the first 1 to 3 years and during puberty. So if you have the best nutrition and calcium sun exposure, you get the best BMD in this age. Low bone mass. So low BMD could result from inadequate accrual of peak bone mass. You have a delayed puberty or drugs, or previous or ongoing losses can happen. Suppose you have a patient with isolated low bone density. What's the significance? We don't know, because some of them with low BMD, known secondary cause, yeah, you have an abnormal bone strength and an increased risk of fractures. Whereas others, you may not have, in spite of when assessed by high resolution peripheral QCT or a transiliac bone biopsy. In one study, they found that isolated low BMD, one of them, same abnormal microarchitecture as those with fractures, and both groups differed significantly from normal control. And in another one, idiopathic osteoporosis showed stable or improved bone mineral density with very low fracture risk over 3. So if you find low BMD, what do? Just follow them up unless you have a secondary cause. Because if you have a low BMD, majority, 50 to 90% of the time, you can actually pick it up. Only in 10% we may not pick it up. And once you achieve the peak bone mass, there is a gradual loss, which is around 0.25 to 1% per year, particularly at the femoral neck. A lot of factors affect this. Say you are lean, you tend to lose. Vitamin D intake, calcium intake not adequate. Physical activity, the stamping activities especially. So when you stamp, it stimulates the osteoblasts. Alcohol consumption inhibits. Family history of osteoporosis is a risk factor. Smoking, number of pregnancies, because you lose a lot of calcium, especially in the last trimester. So premenopausal women and BMD, why this? There is no concurrence, because it's not the same. Minus 2.5 increased risk of fracture postmenopausal women, the same thing does not apply in premenopausal women. So one study, premenopausal women with Colles, BMDs at the non-fractured radius, lumbar spine, femoral neck, significantly below age-matched peer. Another one, distal radius fractures, they had similar BMD at the wrist, but when they did a high-resolution peripheral QCT, it did show deterioration at both distal radius and distal tibia, though the BMD was normal. So do you screen everybody for low BMD then? So routine screening, not recommended. So only if there is a history of fragility fracture or an ongoing medical disorder. Say you have an IBD, inflammatory bowel disease, patient is on steroids, glucocorticoid deficiency, excess, or estrogen deficiency, you do it. So what are the guidelines? History of fragility fractures, do a BMD. Diseases or condition associated with low BMD, hypogonad, etc., do it. Medication associated exposure associated with bone loss, do it. And you want to initiate therapy, then also you should do this. But many times we just do left and right, and we end up some people having with low BMD. So how to go about that? Anybody comes like this, thorough history, physical examination, lab required. I told you, 50 to 90% secondary causes easily detectable. Of course, you should look into the lifestyle choices like alcohol, tobacco use, dietary habits, calcium, vitamin D exposure, physical activity discussed. Family history of osteoporosis. So these are the conditions. Anorexia nervosa, vitamin D deficiency, hyperparathyrotoxicosis, hypercalciuria, type 1, type 2 diabetes, Cushing's, hypogonad, RA, alcoholism, CLD. Some examples. Drugs, dipomedroxyprogesterone, excess thyroid hormone, cyclosporin, anticonvulsants, aromatase inhibitor, cytotoxic, heparin, SSRIs. So these are the list of tests what you have to do. CBC, electrolyte, renal function, calcium phosphate, calcium profile, TSH, 25 hydroxyvitamin D. You can do in some cases 125. Then LH, FSH, prolactin, PTH, celiac screen, very important. Bone turnover markers in certain cases, ESR. If you don't find anything, you could probably try doing a iliac biopsy. So coming back to her case, she had a low set ear, no blue sclera, multiple dental caries with loss of teeth, absent little toe in the right lower limb, which was a trauma related, and bone deformity in the right leg. Systemic examination normal, except she had painful restricted movements. That's why it was less. Otherwise, power is actually normal. So you can see here some fractures you can see here, like Looser's Stone types. in the fibula also, in the femur also you can see. In the humerus also you can see some fractures. Clavicular fracture, that's why she had that braces then. And this, the spine is looking a little bit denser, in fact, and probably she is using, I mean, she takes bore water well from Gulbarga area, so most probably some amount of even fluorosis we can think about in this type of patients. Calcium profile was normal, phosphate was 2.45, but she came initially telling that it is a hypophosphatic case because her phosphate was 0.8, but then vitamin D was also low. We challenged it, improved to 2.45. That's quite some time back, and it's remaining at that. We did a TMP GFR, that was, I'll come to that. Vitamin D, 125 dihydroxy was 156, and vitamin D 25 hydroxy was 22, that's slightly low. So at least this rules out FGF23 as a cause, so we could rule out hypophosphatemia because of vitamin D as a cause. CBC was fairly okay, nothing much. This is how she is. Loss of tooth, some bony deformity you can see here, mainly because of the fibula fractures. So how do you manage this? In general, adequate calcium, there's no recommendation, everything is expert opinion. So adequate calcium, especially from dietary sources, adequate vitamin D intake, maintain above 30 nanogram, weight-bearing exercise, cessation of smoking, avoid excess alcohol, caffeine, phosphorus-containing sodas, maintain normal weight, avoidance of extreme thinness or weight cycling, suddenly gaining weight, suddenly losing weight, avoid this. So if you find a secondary cause for that, you, for example, celiac disease, gluten-free diet, parathyroidectomy, anorexia, see that restoration of weight, hyperprolactinemia, dopamine agonist, or if they are hypogonad, estrogen with progesterone therapy. In general, pharmacological therapy for osteoporosis is not recommended because there's no data long-term effect, so that's why we don't know what is the thing. But then if you could reserve it for those with fractures, accelerated bone loss, or known ongoing secondary cause of osteoporosis accompanied by fractures or bone loss. So you have a young woman without fracture, then what do? Wait and watch. Monitor them, repeat a DEXA after 1 to 2 years, give them calcium and vitamin D, tell them to follow exercise and those measures. You have fractures. If you are hypogonad, E2 plus P, anorexia nervosa, if you have adult women, you can give them E2 plus P once again. Say sometimes they don't respond in these type of patients, you have to give bisphosphonates. Mature adolescents anorexia have substantial BMD improvements with transdermal estrogens. What are the drugs tried? Bisphosphonates and teriparatide. You don't have long-term data, so you should deal this in a case-by-case basis. So when you decide, okay, I want to treat, if you have a fractures, yes, probably you could treat because we know we are dealing with a case of a low bone mineral density with osteoporosis. But if you don't have, you could probably do what is, you can do bone turnover markers, and if they are high, so that's an indication probably we should treat in them. Teriparatide has been tried in some of them who couldn't use bisphosphonates for whatever reasons. So it has worked well even in young women with idiopathic osteoporosis and anorexia nervosa. I won't go into this because less times. Yeah, bone turnover markers, less or minus, but you could still use it in them. Okay, so coming back to her case. So what did we do for her? We optimized her calcium and vitamin D, sent samples for genetic workup to rule out OI because that's the most commonest cause. It's not hypophosphatemia. Even if the genetic workup comes positive or negative, we thought we'll start her on pamidronate. So this is our approach for her. So to conclude, the diagnosis of osteoporosis in the young should not be based on BMD alone. Both the ISCD and IOF emphasize that low BMD must be coupled with ongoing secondary causes of low BMD, accelerated bone loss, or presence of fragility fracture to define a young person having osteoporosis. A high proportion have secondary causes of low BMD, a thorough history, physical examination, lab evaluation mandatory. You should target the secondary causes, see that whether it can be corrected. And in severely affected where there is no cause, which is idiopathic osteoporosis with very low BMD, in these type of patients, pharmacological therapy may be considered. Thank you for patient hearing.